Today, inshallah, I will speak about minimally invasive surgery for aortic valve replacement, and then I will speak about TAVI. So, introduction. The STS database defines minimally invasive cardiac surgery as any procedure not performed with a full sternotomy and cardiopulmonary bypass support. However, the only procedure represented by this definition is TAVI or TAVR. Nevertheless, in 2008, a scientific statement from American Heart Association defines minimally invasive cardiac surgery as any small chest wall incision that does not include the conventional full sternotomy. Why we are performed or doing minimal access aortic valve surgery? There is many reasons being mentioned in the literature. I will mention some of it. Cosmetically superior incision, proven to reduce post-operative pain, faster post-operative recovery, as in many literature. It will improve post-operative respiratory function as well. No difference in mortality between two brackets, safe, and this is very important. Any innovation in cardiac surgery or advancement in cardiovascular specialty need to be safe. Provide access to the relevant parts of the heart and reduce dissection of other areas, and that will translate to less requirement for blood transfusion. And it will greatly facilitate a reoperation at later date as the lower part of the pericardium remain closed, and that will give you a chance or a better entrance for when you are performing a reoperative cardiac surgery for other causes than aortic valve. So what is the principle of surgery? Minimally invasive surgery. Now, today I'm just talking about the aortic valve replacement. The most important thing is that you can apply safely a stable aortic cross clamp, ability to visualize the aortic valve completely and perform a successful replacement with all the standard techniques, ability to achieve the same degree of myocardial protection as through a midline sternotomy approach, ability to deal with any issue of aortic root, ascending portion of the aorta, as well as the arch of the aorta with a relative ease and without conversion. In the literature, you can perform AVR, you can do aortic valve repair, Pental, ascending replacement, as well as hemi-arch with also complete arch with frozen elephant trunk through this axis. Ability to quick convert to a standard midline sternotomy if compromising situation arise during the operation. So another important thing, and that can be safely performed if the following are available. Keep in the mind that any minimally invasive approach, it is a program. It's not a one-man show. So this some of the points that need to be in our mind, not limited only to this, to perform minimally invasive program. One, you need to have experienced cardiac anesthesiologist with you, TE in the room, ability to place pulmonary artery catheter with pacing capabilities and transjugular coronary sinus catheter if you need it with the help of the anesthesiologist for retrograde, of course. Ability to place percutaneous arterial and venous cardiopulmonary bypass cannula. Ability to use a vacuum-assisted venous drainage on cardiopulmonary bypass. Minimal access retractors and other relevant instruments. As I said, it is a program. You need to have a full instrument related to this kind of procedure. Ability also to remotely monitor myocardial protection and distension by TEE. As all you know, any myocardial distension will lead to, it will affect the myocardium. And the most And one of the most important thing, you need to have a surgeon experience first with a conventional aortic valve surgery, then he will do a minimal access surgery. First, you need to be safely and competent surgeon performing the standard AVR through full sternotomy. Then, as all you know, you need to do a fellowship or a program, or you be with some senior consultant be with you through this journey. So how many surgical approach for minimal access? We have in the literature 4, of course, we are currently using the 2, which is upper hemisternotomy and right anterior thoracotomy. In the past also there was, in the evolution of minimal access, we have right parasternal approach and also transverse sternotomy. I will start with one of the famous one. It is upper hemisternotomy. Surgical technique, opening 6 to 10 centimeter midline skin incision, starting at or just above the manubriosternal angle. Then the sternum is opened in the usual fashion, starting at the sternal notch and up to the 3rd or 4th space, according to your desire, using a narrow blade oscillating saw, or you can use a conventional saw as well that we use, is extended into the right or left space. 4th intercostal space usually gives the best exposure, especially in the beginning of your career. It's advised to go with the 4th, and with more and more experience, or if you have experienced mentor with you, you can go with the 3rd one, and also depend on what kind of procedure you want to perform. Just isolated AVR, pental, ascending aorta, it's depend, and according to that, you will choose the extent of incision. The most important thing that the incision has to be midline to avoid fracture of the sternum, because that fracture will result in 3 sternal fragments. You don't need to prophylactically ligate the internal mammary artery, because usually it will retract gently. You can use cross-Baxter retractor to separate the sternum, or any other kind of retractor that will help you to perform this procedure. The most important thing is exposure. So you need to use a pericardial suture to retract the pericardium and reapply the retractor. One of the tricks that you can retract the pericardium first, like by Kocher, then you apply the retractor on it, so that will open all the area for you like a puck. Then you can use a pericardial retractor. It's been mentioned that you can use 3 to 4 pericardial well suture to have the best exposure. You can do either T or G incision. At the end, you will have the very small incision, very cosmetically cosmetically very nice for the patient, like this one. The exposure actually is excellent, and it will give you the same exposure of the aorta to perform the standard AVR. For cannulation, you can do aortic cannulation in the usual fashion. Venous drainage, either if you have a good access to the right atrium, you can cannulate directly, or you can do femoral cannulation through cylindering technique, and size usually it's 20 to 22 French. And you need to use the TEE to be sure for the proper positioning of the proper positioning for the venous cannula. Retrograde cannula, it can be inserted in the coronary sinus either via right appendage or guided by TEE, or it can be by the help of the anesthesiologist via internal jugular vein. The operation, it will be in the usual fashion after going on pump. Some couple of notes about coming off. If the heart goes into ventricular fibrillation, percutaneous defibrillator pads put before the surgery at the use. And this is very important. Before you start your operation, you need to have the percutaneous pads attached to the patient. Subxiphoid mediastinal tube are put before coming off bypass because if you resume if you take the cross clamp off, it will be dangerous to put the drain. So it is advisable to put the drain before coming off pump, before coming off, sorry, cross clamp. And if you forgot to do that, it is better and safe to put the right or left chest tube. Space wire, as in the usual fashion. The de-airing, it's a combination by ventricular fairing, table positioning, external decompression, and also with the help and guide of TE. The closing use 3 or 4 horizontal sternal wires and an oblique wire placed between the lower intact segment of the sternum and the angular segments of the incision. It's like this one. So 1, 2, 3, the fourth one, as I mentioned, the drain before you are coming off pump, the pacing wire, either you take it from the usual places below the xiphoid process, or you can take it from here, but be aware not to injure the intercostal vessels here. The other approach, which is right parasternal approach, the vertical upper right parasternal incision in the second or third and fourth cartilage were removed, and the right internal mammary artery ligated and divided. Not all the surgeon divided or doing that. Gives the same exposure as hemistonotomy approach, and the surgery will be proceeded in the same manner. The main complication is a high incidence of a lung herniation. With this approach, nobody is using this approach currently, and physiologically disturbing and cosmetically disfiguring. Second surgery with a mesh repair also is needed. So they use this, they took the ribs out, but this is not being used anymore. The other one in the evolution of the minimally invasive is transverse sternotomy approach. So 8 to 10 centimeter transfer incision made over the manubrosternal angle, extended into the either side, bilateral second costal cartilage is excised, and both internal mammary artery is divided, and transverse sternotomy is performed across the sternal edge. Sternal edge are retracted in craniocaudal plane. But what's the problem with this approach? Venous cannulation, retrograde, coronary sinus, catheter placement, left ventricular vent placement, except transaortic, may have to be performed percutaneously with this approach. Never gained popularity because of sacrificing both internal mammary artery, and with a high incidence of morbidity because re-exploration for the bleeding because of the both ligation of the coronary artery, also being observed that paravalvular leak and longer hospital stay and mortality with this approach in the literature. This is the approach in the third intercostal space, transverse incision. The last approach that we've used for minimally invasive aortic valve, which has been used a lot either with a direct vision or thoracoscopic for AVR, right anterior thoracotomy approach. It's used in patients where sternotomy is to be avoided by all means, like crutches-dependent patients and those with a heavily irradiated sternum. You need to avoid opening the sternum of those patients. Incision is via the second right intercostal space to the sternum edge. If exposure is inadequate, may be extended via transverse sternotomy just below the manubrosternal angle. The right side of the aorta is visualized, and with pericardial retraction suture, the area of interest could be moved into the operative field or toward you, I mean. So it is in the second intercostal space. You open and you have actually great exposure for that. The real question, the other question now, what is the role of imaging and in minimally invasive aortic valve replacement? It is very important to review all the imaging before going for or doing minimally invasive transthoracic echo plus chest X-ray plus transesophageal echo if it is that done. And it is very important to do the CT scan, especially with the right anterior thoracotomy, because in the CT scan, if you can see here, you can do the 3D reconstruction. It will give you the proximity of the ascending aorta toward the right anterior thoracotomy. Is it near you or away from you? And that will facilitate and give you an idea about the complexity or difficulty during doing minimally invasive aortic valve replacement. Other many literature, you can find it being mentioned. It is very important for planning for minimally invasive. The key steps for the patient assessment, you start to do all the investigation, CT scan, history, physical examination. Other important one to predict the difficulty for minimally invasive aortic valve has been published, I believe, in European Journal for Cardiovascular cardiovascular. And here, this is what very nice schematic showing how you will calculate. For example, the incision point in this example, it will be in the right mini thoracotomy, and you need to measure the distance between your incision point and the aorta or aortic rule, the sinotubular junction, and the angle related to that. So that will give you an idea about your plan or your operative planning before going to do this procedure. Also, you can do 3D imaging, and you can choose the proper incision site for you, which will relate to the proximity of the aortic valve or aortic root towards you. I will speak a little about minimally invasive aortic valve surgery, the Cleveland Clinic experience. Cleveland Clinic, actually, they are pioneer, and they started the innovation for minimally invasive. If you can see from 1995 to 2010s and even now, you have increased frequency of using of minimal access or minimal invasive aortic valve replacement throughout the year. Even in 2006, with the introduction of the TAVI, you can see the increased number of TAVI as well, and increased number also of minimally invasive aortic valve surgery. From their cohort of patients, they have some consideration for incisions choice. For example, if you want to do mini thoracotomy, this is for isolated aortic valve surgery. Also, you can do aortic root enlargement with it. For upper hemistenotomy, actually with upper hemistenotomy, you can do all kinds of aortic surgery, either isolated aortic valve with root replacement, root enlargement, ascending aorta repair, hemi-arch replacement, and also, as I told you, frozen elephant trunk if you want to do that. It's been mentioned that if you want to go for full stenotomy, according to their paper, if you want to do valve sparing root operation or total arch replacement. However, recent paper, they give the same, or that you can safely perform both of these two operations through upper hemistenotomy as well. But with a case of severe aortic calcification or mitral annular calcification, or you want to do another procedure, at that time you need to go for full stenotomy. Okay, what's the outcome of minimally invasive aortic valve replacement? Many literature being mentioned and give you that the outcome for this kind of procedure is safe, and actually in some of the literature, it's even superior to the full stenotomy. For example, in the meta-analysis for mini AVR from the same review paper that been published in 2019, and it been published in the European Journal for cardiovascular cardiothoracic surgery. If you can see, the mortality is 1.9 versus conventional AVR 3.3 with a significant p-value, less renal failure, of course, less requirement for transfusion with a significant p-value, good, the intubation time periods is less, ICU stays less, hospital stays less, even the pain score is superior. A personal data also from St. Thomas Hospital, especially with the patient with a comorbidity, they will benefit more from minimally invasive AVR, especially patient with COPD, diabetes, even patient with a low ejection fraction. There is many paper showing that those patients with a low ejection fraction, you can safely perform for them minimal access AVR as well. A post-operative complication, even according to this paper, is less. Is less with a minimally invasive approach, and renal failure is less. Intubation, of course, or prolonged intubation is less. Deep wound infection, because you are, and of course this is less because you are keeping the integrity of the sternum. If you have any question, because I will proceed now about the sutureless aortic valve replacement and how that will facilitate a minimally invasive AVR. Okay.
Can I comment?
Yes, of course.
Okay, so very good looking at the literature of minimally invasive aortic valve. Okay, so as you said, the most common two approach is mini hemisternotomy or right anterior thoracotomy, second intercostal space. Most of the people now, they use actually the hemisternotomy because this is give you the same exposure of aortic valve, and you'll be able to conduct the surgery as if you're doing a regular AVR with full sternotomy. So the most important thing, the most important trick is to get the incision correct and to retract the pericardium, because when you retract the pericardium all the way up to the sternal edges to the skin, when you apply your retractor, this should pull the heart up a little bit. And also when you open the aorta, you have to, as you see me doing aortic valve, I always put retracted stitches into the edge of the commissure of the aortic valve. This also should pull the aortic valve and the aortic annulus more superiorly or more toward the head, and this will also give you a better exposure to perform your aortic valve. In terms of cannulation, 90% of the time you'll be able to cannulate centrally, but if you have issues with the venous cannulation, sometimes there is a valve into the IVC, you cannot get the cannula in, or the right atrium is small, or you don't have a full and good exposure for the right atrial appendage, or the appendage is very frail, then you can cannulate the right femoral vein very safely with cylindrical technique, and you can actually, after you finish the case, you just put figure of 8 and take out the cannula. I won't recommend you to put a retrograde, because most of the time it will be very difficult to get it in without palpation. Even if you get it in, you need the TE guidance. Sometimes your anesthesia is not expert with that. But my advice to you, you would give a very good dose of antigrade cardioplegia in the beginning, and then use direct coronary perfusers. That will give you this you can control. You're sure that you're giving the bleach into the coronary artery. The other thing is the most important thing, you have to put an LV vent, because if this LV dilates and you're on hemisternotomy, you'll not be able to see. One of the cases I did here, actually, when we come off, we have LV vent, but I was told that it's across the mitral valve. It wasn't, so the heart was distended, and the patient goes into recurrent VTAC. And when I filled the heart was very distended. So I readjust the vent, I put the vent across the mitral valve, and then we'll be able to vent the LV This is very important in terms of de-airing and in terms of protection. The other thing is when you do a hemisternotomy, if you're not comfortable, if you see that you don't have very good exposure and you will not be able to perform this operation very well, do not attempt it. Just do a full sternotomy. In terms of imaging, there is a lot of papers talk about CTs and stuff. I don't do CT scan for many sternotomy AVR, especially if the patient's young. And if the X-rays, the most important thing, what I look at for X-ray anterior. I look at PA and lateral views, because on the X-ray, you will be able to see the aorta if it's right-sided, and you'll be able to see also the aortic root and what is the relationship to the intercostal space. And this you will alter your incision. You will go into the fourth. Sometimes if the aorta is very deep, sometimes and if the patient have ascending aortic aneurysm or long aorta, the aortic root will be pushed down a little bit, especially if it's in a thin patient when the heart is smaller. So you really need to alter your incision. Instead of going to the fourth intercostal space, sometimes you have to go up to the fifth intercostal space to be able to get to the aortic root safely. And also positioning of the patient in the operating room is very important. As if you guys notice, when I do these cases in the operating room, we put the patient head up about 30 degrees, because this will give you a better exposure to the aortic valve. Instead of looking at the aortic valve into a perpendicular, you will look at it horizontal view. This is hemisternotomy. In terms of the second intercostal space, this will give you a little bit more small incision, but it's sometimes cannulating the aorta centrally will be a little bit of challenge. You could do it, but I recommend you, if you're gonna go for a second intercostal space aortic valve replacement, to do a full peripheral cannulation, femoral artery, femoral vein, and to also have a cheat with clamp, minimal invasive available, because sometimes clamping the aorta is not easy. So and also to have the kit of long aortic vent, and I mean the root vent and cardioplasia, because sometimes the aorta is a little bit deeper and you need a longer cannula. And also to have the minimal invasive instruments kit around, because sometimes doing the AVR with the regular instruments from the second intercostal space, it's a little bit challenging with the regular instrument. So sometimes you need the MIS, which long shafted instrument, to be able to do that.
Yes.
Okay.
One question, from what I understand from my reading, that the CT, I understand from my reading, I don't need the CT if I want to do upper hemisternotomy. But if I want to do the right, the mini thoracotomy, the right anterior approach, that I need to do the CT to see, is the aorta lying towards the right side, towards me, or is it pushed away? Is that my conclusion from my reading? Is that true, that I need to do the CT for the right anterior mini thoracotomy or not?
Yes.
Yes, you need to do a CT, but also if you're planning to do any peripheral cannulation for minimal invasive surgery, and you will see when we launch when we restart our minimal invasive program, we will have a specific CT scan for minimal invasive cases. Because you also need to look at the femoral arteries, and you need to look at the whole aorta, because you'll not be able to embark in minimal invasive approach and you have a problem with your cannulation strategy. So yes, you need to get a CT to look at the alignment of the aorta. And you need to look at also, if you're planning to do mini thoracotomy, yes, you need to look at where is the position of the aortic root, where is the position of the aortic annulus, how far is the aorta from the second intercostal space. Yeah, this is important. But I will not recommend you to, if you're going to start minimal invasive aortic valve, I would recommend you to start with hemisternotomy, because it is like mimicking you're doing an aortic valve, okay, like a regular sternotomy. And instead, you don't have the full exposure for the heart. And it's a little bit challenging in terms of you're working in a little bit of confined small spaces. But when you start your career, and you did not do much of aortic valve, do not jump into many sternotomy. Just there is no shame of doing it full sternotomy AVR, and you do a very nice, beautiful operation in the beginning till you have the all ergonomics and the all angles and all techniques of aortic valve. Because sometimes you will be surprised in aortic valve, you'll start with a very simple operation, but it ends up a very big operation. Like if the whole aortic root is calcified, you need to do Bental, then you have to be ready to do that, you know. And if there is also a small aortic root, you sometimes be surprised that you need to do root enlargement. So in the beginning, just go for full sternotomy aortic valve. And when you're happy with all the techniques and all the tricks and tips and the aortic valve, then you move to hemisternotomy. When you're comfortable with hemisternotomy, you move to the next level, which is right anterior thoracotomy.
Okay, clear.
Just want to add one comment quickly. You know, when you are planning to do this, the cardioplegia, I think, you know, what I do it now is a custodial cardioplegia. Just clamp it, give a custodial cardioplegia, single dose, you are relaxed for no more than 2 hours. So you don't have to push every time and stop your surgery. So, and there is lots of experience with custodial, particularly the valve cases. So you should work, you know, try to work with the custodial cardioplegia. And second thing is a CT. In sternotomy, we don't need usually, like you are operating a 30, 40 years patient who unlikely to have. But if you are doing an mini AVR in 60, 70 years, I suggest you should do the routine CT, not only to see the angles and where it is, but also to see the, you know, aortic calcification. Muhammad was telling, you know, you may change your plan. His RH is calcified, his vessels are calcified. So all elderly people, I suggest you should do a routine CT. And for if you are planning to do thoracotomy, mini thoracotomy, yes, every case you should do. Even the young patient, you should do a thoracotomy because it is very important to see the depth. Thank you. Anything?
No.
Very good comment, Abu Shabir, of the cardioplegia. But I want to tell you something now. Most of the cases that are going to come to you now, most of them, they're young, looking for mechanical valve. Most of them, they have a bicuspid valve, and most of them, they have AI. The last 3 cases I did, it's bicuspid valve with severe AI. Yeah. So this is very challenging in terms of in terms of protection. You cannot use crystalloid and crystalloidal. What Shabir said. Maybe he can use it, but what I would do in these cases, I would give the patient a dose of cardioplegia, like around 500 to slow down the heart, because the heart will never arrest. And then when the heart fibrillates, I will open the aorta and give directly into the coronary ostium, and give a very good dose, about 1.5 liter of regular bleach. Then you have 30 minutes to work, and then you can give another dose, you know, if you need. But the most important thing when you deal with these cases, in the beginning, do not do mini sternotomy, please. If you have issues with the severe AI, because you're going to have a lot of issues with the protection. So in these cases, do full sternotomy, put a LV vent across the mitral valve, and be ready to give the patient direct cardioplegia into the coronary ostium, or have a retrograde cannula in place if you're comfortable doing it. But when you develop the experience to do this, then you have to be ready to give the patient to arrest the heart with a single shot cardioplegia, like with a small cardioplegia till the heart slow down, and then open the aorta and give directly to the coronary ostiums. This is another important point.
Yeah, absolutely, Muhammad. You should avoid, you know, in severe AI, particularly when you are at beginning. What I do is, you know, in the AI, you put a patient on bypass, put a LV vent, and then cross clamp and do a aortotomy, and do, you know, because your LV should not distend. I just put across, I do an aortotomy and give directly to the, and put the ventus on, put a vent through the aortic orifice and through the LV vent, put them both and give directly to the, because you don't have an access. You cannot monitor the distending. It is very difficult. Anesthesiologist, you will tell him it is very difficult. But try to avoid, as Muhammad said, try to avoid the severe AI unless you have a good experience.
Okay.
Go ahead. Thank you.
So now I will speak about the sutureless aortic valve replacement, there is many there is many paper recently published about the sutureless aortic valve, and for example, sutureless versus conventional aortic valve replacement. Was the outcome in 70 high-risk patients with a concomitant cardiac procedure. Was published in 2018, and they found that with a high-risk patient who underwent multiple cardiac surgical procedure, the sutureless AVR have better hemodynamics, and we will talk about that. The valve itself has a better hemodynamics than conventional valves, and with shorter ischemic time than the patient underwent the conventional AVR. And you can see from this paper comparison between pre and postoperative echocardiographic finding, almost the same preoperative characteristics, and they found that the sutureless AVR performed or was in Kaplan-Meier survivor curve trends to be better without significant p-value. Another, especially in the beginning of introduction of the 3F-enable valve, the clinical performance of the sutureless 5-year result and long follow-up result, at the end they found it is good to be used, the 3F-enable, and with a better hemodynamic with those kind of valve. However, we have the 3F-enable, and we have Edwards and the Perceval. One of the randomized multi-center trial, and they compare minimally invasive rapid deployment versus conventional first sternotomy aortic valve between the two groups, a total of 100 patients with severe aortic stenosis. At the end, they found that the use of minimally invasive approach with help of rapid deployment or sutureless aortic valve resulted in significant reduced myocardial ischemic time and better valvular hemodynamic function than the full sternotomy conventional AVR with a stented pyoprosthesis, and the rapid deployment valve may facilitate more the performance for minimally invasive AVR. And this is their arm, 1,000 patient, both one with a full sternotomy AVR and with a rapid deployment, and they use Edward Intuity valves as you see. And this is all the cross-clamp time were less, cardiopulmonary bypass, there is no difference, operative time, no difference, implanted valve size, no difference, but the hemodynamic was better with rapid deployment valve. Then recent review articles in 2018 talking about the 10-year experience, especially with the Perceval. Actually, even the literature and even in the practice, the Perceval is more and now is more and more having popularity than the other type of rapid deployment valve for many reasons. What is the specific use for the Perceval? Sutureless valve in minimally invasive approach can be used if you have small calcified aortic annulus, because the Perceval or the rapid deployment sutureless valve have the better hemodynamic, as been shown in many literature, than the conventional stented bioprosthesis that we use, and also is very useful for combined procedure to decrease the cross-clamp time plus cardiopulmonary bypass time. There is a special uses and off-label application for Perceval in the setting of failing homograft. You can go in, fire it, and through that calcified failing homograft, and also in the bicuspid aortic valve. Keep in mind that the Perceval, like in TAVI, the indication to be used for severe aortic stenosis tri-leaflet valve. not for bicuspid valve. This is commercially available sutureless aortic valve, 3F enabled. I'm not aware. It's not. According to my knowledge, it's been not that popular nowadays. The Percy valve is the one popular from Sorin, and the Intinuity Elite from Edwards also been used. This is intraoperative view of the Percy valve. The trick I want to mention, the trick about using Percy valve, you know that if we are doing aortic valve replacement, that we have to be like 2 to 3 centimeters above the sinotubular junction. However, in the Percy valve, you need to be like 6 to 8 centimeter above because of the stent. And you have to have the 3 guiding suture in the nadir of the valve to guide the valve in. Then you do the deployment of the valve. Then you use the balloon to inflate the valve and to inflate the stent. And this is very important when you want to do Percy valve, especially in the beginning. You need to have a proctor with you or a mentor to show you how to do this, how to implant this valve safely for the patient, especially planning for this valve 1, then deployment of the valve 2, and also sizing of the valve. There is a tip and tricks about implanting the Percy valve. We will discuss briefly about it in the coming next slide. Currently, we are all waiting for, I think it will be, according to the Sorin company, it will be published maybe within 6 months, something like that. Persist AVR. What is Persist AVR? It is a trial started in 2016, comparing the stented bioprosthesis, different kind of stented bioprosthesis, against the Percy valve sutureless, and we will see the outcome of this trial, I think by the beginning of 2021, according to the Livinova. Percy valve bioprosthesis, it is the bovine pericardium from the solo valve multiform. It's truly the sutureless valve available in the market. There is no leaflet cramping like in the TAVI valve. It is rapid implant. It came in different size, actually, 4 sizes: small, medium, large, and X large. Enhanced, conventional plus minimally invasive procedure, and it is reproducible, and also it seems easier for the resident to perform the rapid deployment AVR. This is a video about implanting the AVR, but I will not, we'll see it later. So why sutureless or rapid deployment aortic valve? Why we are doing that? According or from the literature, it will, because reduction in cross clamp and cardiopulmonary bypass time, it will facilitate minimally invasive surgery. From the literature, excellent hemodynamics outcome, and also for small aortic valve annulus, especially with the Percy valve S, facilitate combined procedure, and that is if you have aortic mitral, for example, plus cabbage, that with the rapid deployment will have less cross-clamp time, less cardiopulmonary bypass time, and also it is good for future valve-in-valve. I will stop here for any question, because after that I will go for the pre-continuous approach. Any question?
Yes, Dr. Haitham, this incision is not 7 to 8, what I know. It is just above the fat pad when you open you do a sternotomy, you open the pericardium, you see there is a fat on the aorta, ascending aorta when it curves. You just give a 1 centimeter above it. It comes around 4.5 centimeter above the annulus from down to up. 6 to 7 will be little higher, what I know. So it should be, usually we give like, we put a cardioplegia in that area. So just give 1 centimeter to it. If you compare to the what we do routinely, you taught me in the routine AVR, it is just maybe 1.5 centimeter above to the what we do routinely.
Okay.
Because the length, yeah. So just want to comment on the incision about the sutureless valve. Yes.
So 4 to
Second
5.
thing is you have to do a routine CT scan in these patients. You know,
Yeah.
because the size, you have to accurately size them before. You should have a good plan before you go to the sutureless. It is not like anything. So like if it is more than annulus is bigger, you may not. Your ratio of the annulus to the sinotubular junction should be less than 1.3, I guess. And the size of the annulus should not be more than 27. And these parameters you check on the best in the CT scan. So whether it is feasible in doing the sutureless or not. And yeah, the rest, sizing, as you said, you should have a senior, you should have somebody who was expert. Even I did a couple of cases, but one of my cases, was a severe paravalvular leak. I have to, it was a minimally invasive, I mean small, but alhamdulillah, we have to put a new valve, but sizing is very, very, very important. I think that comes with experience, how much to debride, maybe some people use little bit calcium in it. But personally, I feel, though I don't have much experience, but I feel like this valve is good. I think we'll do, inshallah, in future we'll do some more cases with the sutureless valve. Okay, go ahead.
Well, I mean, we used it multiple times in the United States, and we ended up all the time with paravalvular leak. So I didn't really like sutureless technique. I agree with Shabir, it might have some implication, but I mean, I did not use it before, and I'm not sure I will be using it in the future, but it's good to have it on a shelf in case you need it. But the problem, it's really the sizing issues and anchoring issues and stuff like this, But yeah, if you're gonna start using this valve, you need to have a proctor with you, and also you need to have a very large volume, because you need to you cannot just do 1 or 2 cases and then you stop and then you're gonna come back and do you need to have a very high volume centers of aortic valve, and to be honest with you, nowadays the TAVI will actually took a very big part of aortic valve replacement. So I think the chance of doing a sutureless valve now, it's very low.
Mm-hmm.
Yes, Muhammad. I agree with Muhammad. Because of the TAVI program, it is very active. So you may not do isolated AVR cases. So where the minimal invasive, come out quick bypass. But usually we will see now the AVR with some associated procedure, cabbage or mitral or something. Then in this,
Yes.
it doesn't matter you do extra 15 minutes. They say save the cross column time. I don't think it makes any difference clinical point of view. But yes, your cross column time is low, but does it reflect the outcome? I don't think so. So, but if you have an isolated AVR, and I think and your parameters fix in this sutureless, I think we might do some cases, very selective, inshallah, in the future. Yes.
Yes, my question, yes, regarding the TAVI versus sutureless valve. There is any differences in terms of indications, in terms of complications, in terms of the long-term outcome between the TAVI and sutureless?
I will come to that later. There is some literature about this topic. However, there is no currently head-to-head trial comparing sutureless or Percy valve with TAVI. Even recently, like 1 month back, I asked the Levinova in one of the webinar. There is no head-to-head trial comparing both of those. There is some data later. I will mention it, but it will be there is a publication bias, or because it's not a trial, retrospective cohort that will affect, and you need when you read it and see the conclusion, take it with caution. Later I will speak specific about this topic.
Okay.
And the most important thing to emphasize more is you need to do what you are comfortable and you know about it, and don't invent something new in your operation room. And if you are comfortable of doing things with for example in cannulation, in opening, don't change unless you have some expert with you, and that expert or mentor will show you new technique. Usually go with the technique that you are comfortable with. If you want to learn something new, don't learn it alone. I hear it from many of my seniors who taught me and my mentors repeatedly this specific point. Okay, any more, or you want me to proceed? Any other question, or I can proceed?
Go ahead.
Okay, so now I will speak about the percutaneous aortic valve intervention. In the beginning, there was a balloon aortic valvoplasty. It was first used on the aortic valve in 1985, and it was proved to be safe for that population being used for. There is two approach initially was done: retrograde approach through femoral artery. The problem was with the small arteries and failure to cross severely stenotic aortic valve. And also there is a retrograde approach reaching the aortic valve via transseptal approach. Once the guide wire positioned across the aortic valve, a balloon valvoplasty 18 to 23 millimeter advance and place over the stenotic area. Then you inflate the balloon with dilute contrast material and the rapid ventricular pacing at 180 to 200 beat to reduce cardiac output and to prevent the balloon migration to be pushed because of the ejection. The mechanism is fracture of the calcified nodules on the leaflet with elastic expansion of the aorta. However, the result of this methods was modest, with a slight increase in aortic valve area from only 0.6 to 0.9. Another issue with this approach was the recurrent aortic stenosis was due to healing of that nodule fracture and recalling of the aorta after that. The overall 1 year survival was 65%, with a 1 year free of death, and AVR or repeat balloon aortic valve only 40%. The mortality was 14% in this population, and you can imagine those very high risk population, and you are using this kind of surgery. So currently it's only indicated for severe AS who is not surgical candidate or hemodynamically unstable, or those requiring non-cardiac surgery or bridge to surgery. However, with advancement of TAVI nowadays, even with a patient that they are not surgical candidate or even hemodynamically unstable or in cardiogenic shock due to aortic stenosis, there is a current paper or rising evidence about using TAVI with those kind of patients. So actually this methods is just, I mention it as a part of evolution of percutaneous approach. This is just to show you how that is done. You go with the balloon across the valve, then you inflate the balloon to create the fracture to increase the aortic valve area to give some relief of the patient. Now, TAVI. So TAVI started actually in 2011 with a partner trial. First, it was inoperable patient, then high-risk patient versus low TAVI versus surgery, then intermittent risk patient, then the low-risk patient. I will speak about it later in this lecture. Just a schematic approach for any patient with a symptomatic aortic stenosis, either there's a contraindication or high-risk surgery. If yes, if you have a poor vascular status, no, you can go for transfemoral TAVI or any other approach, transaortic or transapical. If there is no, if the patient, there is no contraindication for surgery, it's not a high-risk patient, if you have severely compromised LV function or concomitant procedure, you need to do open full sternotomy AVR. However, about the LV compromised function or severely compromised, it's debatable, but it's better to go with a full sternotomy if severely compromised. No, you can do MIS as we mentioned in the beginning of this lecture. Multiple approach, the most popular is the transfemoral and the most actually safe with a good result. However, sometimes you cannot go for transfemoral when you do your pre-op workup with the CT scan. You have a problem with the access, either iliofemoral disease or severely calcified or tertious artery. So you have to go for other alternative approach like transaortic or transcarotid, transaxillary, transapical approach. All that kind of approach you can use to deploy the TAVI valve or TAVR. Despite the growing experience with the transaortic valve replacement, the first generation devices were associated with several limitations such as valve malpositioning, vascular complication, paravalvular leak or regurgitation, and also conduction disorder. Several new generation of TAVI devices aimed at addressing all these issues. Characteristics of the new generation, we have many generation. The multiform like Evolute R. Now we have the Evolute R from the Medtronic, CBN3, balloon expandable valve, self-expandable طبعا Evolute R, Lotus valve also now in the market, Porticue and Gina valve. And we in our center we have a good experience with Evolute R valve. This is a transcatheter heart valve. You have Edward CBN valve, Medtronic core valve, Evolute R, and the latest one is the core valve, Evolute Pro. And there is a Boston Scientific or Lotus, Abbott, Boston, all these kind of valve is in the market currently. What is summary about the indication of the TAVI? The partner randomized trial have demonstrated that there is a superiority of TAVI over standard medical treatment, including balloon valvoplasty in patients with severe AS inoperable, which is from the partner 1 cohort B trial. And also there is non-inferiority of TAVI versus SAVR in high-risk patient accepted for both treatment approach. Recent guideline recommended TAVI for very high-risk patient if you have a life expectancy more than 1 year, they are unsuitable for SAVR, inoperable, or high surgical risk as well according to multidisciplinary heart team decision. The latest guideline, just to highlight, we will have lecture about the guideline later, but just because of the sake of this lecture, so the choices for TAVR versus surgical AVR in patients with severe symptomatic aortic stenosis. First, if you have prohibitive surgical risk, TAVR is a class 1 indication. Currently, high-risk patient, you have a class 1 indication for AVR or TAVR. For intermittent risk, surgical still in the recent guideline is a class 1 and TAVR is class 2A. For low surgical risk, surgical AVR, no TAVR. But we know now the low surgical risk, they use TAVR also and TAVI for them, sorry. Although TAVI is indicated only for patients with a severe symptomatic calcific aortic stenosis, it has been used in number of additional off-label valvular pathology. Keep in mind, this is for severe, the TAVI, I mean severe AS, tri-leaflet. So what is other off-label indication? It's been used. It's been used with bicuspid aortic valves, and there is a growing experience with that, but it's not recommended or it's not in the guideline. Why is that? Because of the issue of aortic regurg, because of the geometry of the bicuspid aortic valve. Also, bicuspid aortic valve is associated with aortopathy. This is why there is a risk of aortic dissection. Other off-label use is pure aortic regurg, reports of off-label use with MCV valve and Edwards CBN valve for the management of inoperable pure severe AR, need for oversize with the risk of annular rupture, which is devastating complication that can happen, with a high rate for valve in valve, because you don't have calcium, you put your valve, you need to put other valve to suit that valve again. So you are using valve. This is why there is a high rate for valve in valve. Degenerated aortic and mitral bioprosthetic heart valve, it's off-label use. Safety and efficacy concern include device malposition, ostial coronary obstruction, and the high gradient after the procedure. So the question now, how to screen patient for TAVI? The most important aspect is the heart valve team. The heart valve team participate in, one, the evaluation of the evaluation of surgical and interventional risk, the assessment of feasibility and exclusion of contraindication for TAVI, and for definition of the anatomical limitation. Core valve evolute are TAVI as an example. Each valve you need to read about the indication and how to deploy that valve, and sit initially, if you want to start this program, you sit with the proctor and you know how to choose the size of the valve according to each company recommendation. For example, in the Evolute Art, you have different sizing. Each size corresponds to the annular diameter, annular perimeter, sinuses of Valsalva diameter, sinuses height. All that you will do it after, you will know it after CT reconstruction. Then you sit and discuss all that issue, and you plan your procedure before doing that procedure. So all that, you see your CT scan, all the parameters need to be discussed before doing. The room setup, transfemoral. This is hybrid room, actually. You have the patient, the C-arm, the echo is here, the operator 1, operator 2, and the assistant, anesthesia, carts, right table, cut down table if you need it. You have a standby machine, and also sterile core valve assembly. Here they will prepare the valve for you after you do your step for deployment of the valve. I will mention briefly this step soon. So the step sizing first, and that after you do CT measurement, then you will choose your appropriate vascular access according to that. Then you will start with the guide wire placement. Then you will have the fluoro load inspection. Then you will start or decided if you want to do ballooning or no ballooning before that, and the size of the balloon based on the current recommendation. Then you will, after doing that, before, just to recap again, you plan your TAVI first by sitting with the heart valve team, if this patient is a candidate for TAVI or not. After you establish that, you establish all the parameters according to the valve that you use, according to the company recommendation. Then you go in, the patient will be in the hybrid room. You put your central line either under sedation or full, either the procedure will be conducted under sedation or under full intubation, depend on the decision of the heart valve team, plus patient situation. After that, you need to have one central line. Then you need to have a temporary pacing wire, most likely through internal jugular artery. Then you have your access. Then you have the guide wire through the valve. Then you start after that the after the guide wire, the projection or the fluoro load inspection or the deployment view. After that, then you will go for the insertion of the system. طبعا, of course, if you want to insert the system, you need to have the stiff wire, then alignment of the delivery system, then the deployment of the system. Then you will do the retrieval assessment, then recapture, then post-assessment after deployment of the valve. I'm just mentioning very quickly, there is a lot of technical details. I highly advise you, especially in our center, we have a very good team. You can be with them. If you attend one or two, all these tips and tricks, you will learn it, and it will be in your mind. So you can go and read more in the cards of, for example, in the core valve for more technical details. For the Sebian, the same actually, just you need to confirm the transcatheter heart valve, as we say, 3D, CT, and echo. Confirm deployment side, right or left, femoral artery, then vascular access, place and conform transvenous RV pacing catheter. It is very important. Then you have to have the big tail catheter in the right coronary cusp. Note some center place it in non-coronary cusp. This is depend on each valve and each protocol of the center. Then establish a coplanar view, sheath insertion, cross the native valve, then positioning of the valve, then deployment of the valve, then assess post-deployment by echo and fluoro. You need to check for the gradient. The most important thing, you need to check for a paravalvular leak, and if any heart block that happen with this with deployment of the valve. Then device and sheath removal, then you do your vascular closure at the end. Of course, there is a lot of details about it, but I'm just giving you like an overview about the topics. So now we'll go for complication of TAVI, and we need to be aware of that, because when you know the problem, you can work on preventing this. I mean, when you know the problem, so you are aware of the problem, so you can work on giving solution and preventing this problem. Complication, vascular complication, like severe bleeding. In recent meta-analysis of 16 study vascular complications with a great range of severity. However, with the new advancement of, new devices, these decreases, the percentages decreases, and it's range from small hematoma to femoral pseudoaneurysm or arterial dissection. It's ranging from 5 to 23%. Reduction in vascular complication and related bleeding have been uniformly reported with the downsizing of delivery catheter and increased experience, of course. Hot topics is a permanent pacemaker implantation and conduction abnormalities. The rate of a new onset left bundle branch block following TAVI is ranging in the literature from 4 to 57%, and is more frequent with the use of self-expanding valve system, and is from 38 to 57% than with balloon expandable Edwards Sebian valve. In the recent low-risk trial with a Medtronic or core valve, the percentage of permanent pacemaker in that trial is 17%. Meta-analysis of 41 study, which included 11,000 TAVR patients, receive either balloon expandable or self-expanding prosthesis, showed a 17% as an average rate for permanent pacemaker post-TAVR. This meta-analysis was published in 2018, and the article is in American College of Cardiology. One point I want to mention, even recent in late 2019, 50% of patients who develop complete heart block or some sort of heart block that needed permanent pacemaker, 50% of them after 1 1 year after implantation, on those cohort of patients, they return to normal sinus rhythm and they don't need more pacemaker. Many risk factor for that, radial forces. This is why in Evolute R, because of greater radial force when you implant the valve, so the numbers of permanent pacemaker is more with that valve. And other risk factor, we'll mention it in this lecture in the next slide. Lower valve implantation, presence of right bundle branch are risk factor for permanent pacemaker. And as I mentioned, radial force also one of the risk factor. The burden of calcification, especially in the non-coronary sinus area that extend down towards the mitral valve, is also being mentioned as a risk factor. And many risk factors in the literature being mentioned for the risk of need for permanent pacemaker. And also there is a growing evidence that the need for permanent pacemaker is associated with worse long-term outcome. Paravalvular leak or regurgitation, moderate to severe paravalvular regurg at discharge is reported to be range from 0 to 24. The grade of paravalvular regurg is linearly related to increased short and long-term mortality, especially increases with moderate to severe. Paravalvular leak was one of the first flows of the TAVI procedure, but in the last 5 years, it's been challenged in several improvements in valve design, deployment technique, and anatomical consideration as well. And the experience. Stroke. As a complication of TAVI, in partner trial, the rate of stroke was higher after TAVI versus SAVR, although the rate of major stroke did not differ, even in the recent literature showing that it's higher stroke rate, but the faith or the small insult of the brain and the long-term implication for that, we need to follow that to see, especially with the low risk patient. Cumulative major ischemic stroke rate at 5 years was 9.7, indicating annual risk of ischemic stroke of approximately 2%, and that appeared to persist up to 5 years. At the same time, cumulative major hemorrhagic stroke, it was 7.3%. In the meta-analysis also, they found a relatively small rate of periprocedural stroke, 1.5, but increased to 30 days to 3.3, and all stroke rate as well. And if stroke developed, that will associated with the 30-day mortality more. The stroke risk is persistent during follow-up, and it can reach as a cumulative 17% in one of the meta-analysis. TAVI and stroke has a complex relationship with a multiple identified factor, usually coexisting in the same patient. If you have patient with a lot of comorbidity, as in aortic calcification, diabetes, operator experience, extent, and the new onset of atrial fibrillation, all that will increase the risk of debris or embolization and at the end the stroke. There is a several protective device has been developed and is under development. However, according to the recent evidence, it's none of them till now proven to be good for protection against or decrease the number of stroke. Additional neuroimaging study have revealed a high incidence, up to 80%, of clinically silent cerebral lesion on post-procedural MRI, and the clinical relevance of this still remain to be followed and to be elucidated in the future. And what is the long-term outcome of this high incidence of silent stroke, especially now we are moving toward the low-risk patient. Any question till now? Because I will now speak about the small talk about the sutureless versus TAVI. Then I will speak about the partner 3 trial. So just a quick talk. تفضل.
Hello?
Yes.
Well, this is a very hot topic, you know, TAVI versus surgical. And as you know now, the cardiologist is becoming very aggressive and he wants to jump into all kind of surgical risk patients. But as you guys know, I mean, partner 3 or low risk trial, it's only 1 year result. This is one thing. The other thing is you really need to talk about guidelines. Okay, so still in the guidelines, low surgical risk, it's class 1 indication for surgery. These patients should not be offered TAVR, as far as I know. Even intermediate risk, you still put the surgical as class 1 and then TAVR as alternative to surgical. The problem with TAVI is you have to think about future. So aortic stenosis, it's a very common pathology. If the patient is above 70, this is no brainer. Okay, send them for TAVR, it's fine. But when you have a young patient who comes in the 40s or in the 50s, even the 60s, if the life expectancy for this patient is 20 years, how are you going to do? Are you going to offer him a TAVI at 450 and then he comes in 10 years and you're going to give him another TAVI? Okay, so I believe we have to have a very good discussion with patients about the options. Okay, I see if the patient, if the patient is 50 years and younger, according to the AHA guidelines, this patient should be offered a mechanical valve. However, most of the patients nowadays, they prefer to have a tissue valve because they want to have, they want to live their life a normal lifestyle without altering their activities or without taking Coumadin or warfarin. However, even though doing a surgical tissue valve, it's actually better because the risk of pacemaker is lower, the risk of paravalvular leak is lower. Because even if you ended up with a mild paravalvular leak, this is long term will give you a little bit of reduction in the survival. And if you give the patient a surgical aortic valve, within 10, because we know that the surgical aortic valve is good for 12 to 15 years. This is already proven in literature. And even with the improvement of the tissue preservation and the technology of surgical aortic valve, I believe the new surgical aortic valves, it might be even last more than 20 years. Okay, so in terms of data, we have the data. We have data of long term of durability of the valve. We're better in terms of paravalvular leak, in terms of pacemaker, in terms of vascular complication. The only thing is that it's a little bit invasive than TAVI, but I think in low risk patients they will tolerate it very well. I'm not concerned about technique. You will be able to learn TAVI. TAVI it's not very difficult. The most important thing is you need to know what's your anatomy, what's your landing zone, what's your deployment angles, all this to learn some of the wire skills. I think the most important step in TAVI is to secure a vascular access, because this is the most challenging thing, to get a ProGlide and to secure on vascular access. The rest of the procedure is not very complicated. For you as a cardiac surgeon, you should have these skills as in your toolbox, because the future of cardiac surgery is changing. The cardiac surgery we practice now is not the cardiac surgery was practiced 10 years, 20 years, or 30 years ago. I believe with the improvement of transcatheter technique, most of the valve replacement will be replaced by transcatheter approach. So you have to be aware, you have to be really trained in surgical valves, and then you have to be trained on minimally invasive approach, and then into the catheter approach, because sometimes you will be faced when they have a problem with TAVR, or problem with the mitral clip, or problem with the mitral valve prosthesis. Then you need to know how to be able to do surgery for the patient. The most important thing, you need to be aware of the data, because when you talk with the heart valve team, with other cardiologists, you need to be aware of risk of paravalvular leak, risk of stroke, risk of pacemaker, because this is how we're going to talk to the patient, and this is how we're going to talk to the cardiologist, and this is how you're going to convince your patients. And it's the most important thing, the way that the idea sells to sell the idea to the patients. If you come to the patient, tell him we're going to crack your chest, of course the patient will say, no, I don't need surgery. But I have a patient who comes to my clinic. He's in the 50s years old. He's a very healthy guy, and he was told by the cardiologist that his TAVI is better than surgical aortic valve. And this is actually, this is crazy, okay? Because there is no data to show that the aortic valve, the TAVR, is better than TAVI in low risk patients. It's not. The trial was done in literature. It's non-inferiority trial, and only it's 1 year results. So I don't know how these cardiologists talking to the patient about low risk patient that the TAVR is better than SAVR. So we're still in a battles. I think you need to go to you need to learn to do the TAVI, but even if you learn to do TAVI, it's dependent on the institution, because some institution, the TAVI is done and it's pushed by the surgeon, and the other is cardiologist. I don't believe somebody has upper hand than the other body, but we work as a team. And the most important thing, you need to know what's your role when you walk in a room, and you know who's primary operator, who's secondary operator. You need also to get experience with getting the vascular access, crossing the valve, exchanging the wire from regular wire to stiff wire. What are the different kind of wire? We use Confida stiff wire or Safari stiff wire. We use a straight wire to cross the aortic valve. We have to put a big tail from right radial, or you can use the other femoral artery. You have to put a pacemaker through right IJ. You have to get the steps in your mind, and you know all the steps, and then you will be able to perform. The most important thing also, you need to learn how to use CT scan, how to get your. It's very simple. When I went to the TAVR course in Chicago, they will show you the CT and the 3D of CT program that you can get to the aorta. Look at the calcification, measure the femoral vessels, measure the annulus of the aortic valve, look at the sinusoidal height, look at the coronary height. You have to get used to all these numbers, and you have to get used to use all kind of valve, core valve or CBM valve. When I was in Canada, we used most of the time core valve, and I did all surgical access. We did transcarotid, axillary, we did transapical, I did even aortic. We do the aortic, transaortic TAVI through the second intercostal space. I think as a surgeon, TAVI room, they cannot run a TAVI without a surgery, because the surgeon have a very vital role in terms of complication, and also vital role in terms of access. Because if they have issues with femoral access, then you can provide transfemoral, trans axillary or transcarotid, or even transaortic. And also, if they run in trouble like vascular access, you as a cardiac surgeon also need to be aware of how to control the vessel and do vascular repair. So far I did here 3 repairs actually for TAVI patients. We did 2 primary repair and 1 batch. So the most important thing, low risk is still surgical. Surgeon is vital role for the TAVI program, and you have to be aware of all steps. What are the different wires you use? What are the different catheters? And what's your and you need to have the skill of wire skills in your toolkit. And you need to know how to do the CT scan and measurement, and talk to the company with valve sizing. Thank you.
Thank you very much. So almost I'm finishing my lecture, inshallah. So just to answer Abdulaziz, he was asking about the sutureless versus TAVI. There is no head-to-head trial regarding that. There is only a match study using propensity score matching. However, you know, with this one, it can be not not accurate data. However, it's been shown from this paper, for example, that it is superior to do surgical sutureless valve in many aspects of this trial. Not trial, I mean propensity match scoring. For the sake of the time, I can send this meta-analysis to anyone interested to see. Now, what is the new and where is the future is going? We'll talk quickly about Nordic aortic valve intervention. The conclusion was this is for the lowest patient. Notion is the first trial reported 5 years outcome after TAVR versus SAVR in low-risk patient with a STS score less than 4. And after 5 years, there was no difference in all-cause mortality, stroke, and myocardial infarction, or these combined. There was no difference in prosthetic valve reintervention. Prosthetic opening area was greater and less mean gradient for TAVR and remain unchanged over time. TAVR continued to have more mild to moderate prosthetic regurg, which is translate in higher mortality later. A new pacemaker implantation trend to be associated with increased mortality from this trial, and determining the longevity of TAVR is required longer follow-up, because in our surgical valves, we know that until 12 years or 15 years, it is very good long-term outcome for our valve. Recently published transcatheter aortic valve or partner 3 trials in the low-risk patient. To highlight important thing, the mean age in the partner 3 trial, it is 73-year-old, and mean scoring for STS is 1.9. As a conclusion, there was no, or main result, no significant difference between the two group in major vascular complication, new permanent pacemaker insertion, or moderate to severe paravalvular regurg. In partner 3, this is only 1 year result. Till now, there is no difference between two. However, stroke is more with surgery, and rehospitalization is more in the surgery arm as well. The composite endpoints is better with the TAVR in 1 year. And month since procedure, death from any cause, there is no difference between two, but from any composite death, stroke, and rehospitalization, TAVR is bigger. But be aware of this. I will mention it later. Rehospitalization, they put it as one of the primary endpoint, which divert the curve towards TAVR as a best in the conclusion of this trial. This is just to show you a subgroup analysis, which actually there is no big difference between both and in the cumulative, but it shows better toward TAVR. For self-expanding valve, core valve, same, no difference in the 2 years between surgery and TAVR. And as I mentioned, one of the permanent pacemaker, see 17.4% versus 6.1% in the surgery arm. It is non-inferiority. I show non-inferiority in 2 years with the Evolute or Evolute R and Evolute R Pro TAVI device. The gradient in all trial, TAVR having better gradient and better aortic valve orifice area compared to surgery. However, even the surgical valve in partner 3 and in this trial showing very good aortic orifice area. We know that TAVR is better, but even if you can see here, aortic valve area 2, 2, 2, and even the gradient, mean gradient, okay, it is 10, 11.2, 12, and for the TAVR 8.4 to 9. So even the surgical valve, the surgeons, they performed this trial, they did a great job as well. The most important thing, because this is, as Dr. Muhammad said, is very, very hot topic, and we can spend hours speaking about this, but I just want you, from what I read, to be aware of the following, please. What is the meaning of the low risk from those trials? Keep in mind that all patients' average age is in 70s. The primary endpoints of partner 3, it was including rehospitalization, and I believe this what divert the curve in that particular point. The long-term risk and impact of the pacemaker, especially in young patients, especially again in young patients, many data currently showing the negative impact of left bundle branch and complete heart block post-TAVI, and the requirement of permanent pacemaker, especially if we are pushed toward doing TAVI for low risk patient by STS score and young patient. What is the fate of giving them permanent pacemaker at that age, especially with a high risk of permanent pacemaker implantation? Paravalvular leak and durability of TAVI need to be followed. All the data we have, even in the intermittent risk, is only 5 years. In the low risk trial, only now 1 year for partner, 2 years for evolute valves. Keep in mind in partner that 24% at TAVR arm had concomitance procedure, and 7 to 8% at TAVI arm in the partner 3. Yani 24% they have like CABG, mitral valve intervention. In TAVI, the calcium is still there. What about the fate of this calcium in the younger patient? And this may need a reference center for the redo and taking the valve out, which may need a root replacement with mitral valve replacement in the future, because the stent is going down. It may destroy when you explant that valve. If you need another valve. The long-term effect on the impact of crimping of the TAVI valve. Some data, it's been arising showed that the negative impact, but a follow-up is needed to prove that. Future TAVI, future of the TAVI, especially in young patients with severe AS, small annuli, and need for future valve-in-valve. When you have more valve-in-valve, small annulus, and the impact of that on the young patient and patient prosthesis mismatch. Valve-in-valve results showed more and high gradient, which is translate to patient prosthesis mismatch, less durability, and that being mentioned in many literature and in meta-analysis in the research currently. More complete heart block and need for permanent pacemaker. So going there, especially for the young patients, all these aspects, we need to think about it and discuss it clearly and to have the clear evidence, because at the end, we need the benefit of the patient, not the benefits of anything else. Do we have to wait for the follow-up? I believe yes, because that will give us more data and more clear understanding of this current situation. Just the last thing I will mention, this is very nice article was published and presented in 2019. The train has left. Can the surgeon still get a ticket to treat structural heart disease? Highly advise all of you to read it. They are mentioning about the recommended skills, as Dr. Muhammad said, for the surgeon to acquire in catheter valve therapy, from the planning to understand the TE, CT, MRI, fluoroscopy, all that to be understandable, and also the wire skills. And there was a proposed or roadmap to do like in the rotation of the cardiothoracic surgeon in the residency, and to do a fellowship specifically for cardiac surgeon, proctorship as well, attending all the national and international conferences. Like you need, actually all of you need to go and see the TCT and read about the recent advance and be aware of that, and read about transcatheter. After, of course, you need to master your surgical. Then if you have a time, at least to have an overview about this, because we want you as a surgeon, not as an interventional Cardiology Society. And believe me, the future surgeon, they will be a hybrid surgeon, and you need to have courses or attending courses for structural heart disease specified for the surgeon. Many example of industry like Abbott, Medtronic, they have a courses for training courses and training program for a specific for cardiac surgeon. All this is suggested fellowship rotation or residency rotation during your residency or fellowship, and recommended numbers that you need to do for this kind of procedure. Last things, the evolution of the surgical valve. We need the perfect valve at the end. It could be beyond the present tissue engineered heart valve. It can answer our question. Is it the valve repair answering the question? But you know, the valve repair is a different topic, but I'm just opening your mind to read more about this topic. This is very nice article, show the evolutions of the surgical valve. You can, it started in 1952, and now we have TAVI in 2020. So the evolution, you know, Hevingal, then Star Edwards and cage ball valves and all, and all that. Thank you very much. If you have any question, please. Sorry, it was a little bit long lecture, but I was trying to make it interesting and small.
A good review, and it was a good presentation, a little bit lengthy. I think this TAVI is totally a different issue, you know. Anyway, we'll have some time, you know, again on the TAVI, and the guideline is focused on the guideline, then step-by-step approach to for our juniors, you know, because this is the future. The surgeon has to get involved in TAVI. There is no other option now, I think so. And Alhamdulillah, in our center, we are, you know, is a hard team, and still, you know, we need to push a little bit more, but Alhamdulillah. So we'll do some lecture on the TAVI sometime again about these evidences step by, and go slowly. You know, this is an academic activity. Here we don't present we have to go each topic, you know, each lecture and each slide should be presented in detail, so that, you know, not to go faster, because this is a learning. We are not presenting our experience or something, you know. This is for learning. So each topic and each slide need to be understood well by all the residents, because we have R1 to R6 to R7 to consultant to senior consultant, like that. So each has a different understanding. So we have to take care of our most juniors when we present a lecture, so that they understand these lectures very well. But anyway, it's a good review and a good presentation. Excellent job.
Okay, guys, just to have some housekeeping